Well, ladies and gentlemen, it's a privilege to be here in the first heart failure meeting of the Israeli one. I was assigned a pretty tough job to discuss mechanical circulatory support immediately after lunchtime. So good luck to all of us. So we heard about the magnitude of the problem of heart failure. We all know about it, and we also heard about the current available medication for the treatment of heart failure, and now we're moving to the next phase, which is mechanical circulatory support, that we can divide or define it in several ways. One of the way we can divide the treatment of circulatory support is like short-term devices and long-term devices. And short-term devices are usually in the form of some kind of centrifugal pumps that can function as a left ventricular assist device, LVAD, right ventricular assist device, biventricular assist device, or extracorporeal life support known also as an ECMO, depends on the way we connect it to the patient. The other group of way we can take care of the patient is the long-term devices that historically used to be pulsatile devices, and in the current area are mainly continuous flow devices, either axial flow or centrifugal flow devices. So if we'll go shortly on the short-term devices that are mainly indicated for patients in cardiogenic shock, there are several pumps. One of the most used or known is the Centrimag, known also used to be known as the Levitronics, which is a centrifugal pump that is supposed to use as a temporary device and is FDA approved for up to 30 days. And again, depends on the way you connect it to the patient. It will function either as a BiVAD, LVAD, RVAD, which you can see from this scheme. One of the drawbacks of this device in this configuration is that you need to open the chest. You need to perform surgery, and usually performing surgeries on patients in cardiogenic shock who has end organ failure and with some coagulation dysfunction might be associated with a lot of comorbidities. But this is the solution. And in a recent study, and as you will see also in the rest of my presentation, most of the data we have regarding these temporary devices is for a very small group of patients and a lot of case report or small series of patients. So in this study regarding the Centrimag, regardless of the way it was connected to the patient, roughly in this very severe patient in cardiogenic shock, the 30-day mortality was roughly 50%. Now, other group of devices are devices that can be used as a percutaneous devices. It might interest you as cardiologists as well, and us surgeons also. One of the devices is the tandem heart, which is a device that also is intended for use up to 7 days. It is inserted via the femoral vein. It's relatively more difficult than the impeller that we'll discuss in a second to insert, because you need to go transseptally in the atrium, so you need someone who knows how to do it. And it can pump roughly 3.5 liters per minute. Some people use it, some don't. Not too much data in the literature about it, and you can see, you heard earlier the discussion about intra-aortic balloon pump, and now you can see that it didn't show any advantage survival-wise compared to intra-aortic balloon pump in patient in cardiogenic shock. The impeller is another player. It started, as we heard earlier, with the impeller 2.5 liters per minute, which is inserted percutaneously. However, it was not proved to be to carry any advantage in survival. There's also the impeller 5, which is much better hemodynamically, but it requires surgical introduction to the iliac artery. And now there's also the impeller 4, which is also a percutaneous device. However, at the moment we don't have clinical data regarding its outcome. Those devices are also intended for use for about 7 days. And from the literature, what we can see is that the impeller 2.5 is inferior as far as survival than the impeller 5 for 30 days survival, 26% with the Impella 2.5 compared to the 50% of the Impella 5. And in yet another study, when you compare the Impella 5 to an ECMO or extracorporeal life support, you can see that the results are similar. And we here, at least us in Bellinson, we adopted the ECMO as our solution for patients in cardiogenic shock because of the lot of experience we gained with this device with transplantation, and also because of its availability and the fact that we don't have Impella at the moment and it's cheaper, and the fact that the outcome, at least as far as we know right now, is similar. So the ECMO is basically a modified mobile cardiopulmonary bypass. It's easy to insert, it is fast, it can be done bedside, and it supports both the circulatory and the respiratory systems. It is not the best left ventricular assist device, since it does not unload the LV and it imposes afterload on the LV itself. And the patient is relatively immobilized, but that's true for the rest of the device, of the short-term devices as well. Usually with the ECMO, what we do, we drain the blood from the venous part of the patient, usually from the right atrium via the groin with a long cannula, take it to the ECMO system and put it back to the patient through one of the arterial systems, usually the femoral artery, it can be the subclavian artery or any other major artery of the body. Now, and I think I don't want to discuss much longer the issue of cardiogenic shock devices, those devices, but the one message that I will tell now and also at the end of this presentation is the timing of introducing those devices. And here I don't expect anyone to read those tables, just show a bunch of case reports and small series of what is called eCPR, which means ECMO for CPR. Patient who had CPR and following the CPR had an ECMO. And the results are bad. I mean, it's about roughly 20% survival. And if you take ECMO with no CPR, the outcome is roughly between 40 to 60%. And actually our own data of about 57 ECMO patient on cardiogenic shock, cardiac, are roughly about 45%. So these are the numbers. So it's much better. So you need, when you see a patient that you feel that you have nothing to give him anymore. I mean, you get everything you know, inotropic support, intra-aortic balloon pump, whatever you think is appropriate. But you see that you're losing control. Don't wait until the patient is developing really end organ failure, anuric, hepatic dysfunction, lactate level going up. Then it's futile medicine. We're not going to help him even if we're going to put him on an ECMO. So the time here is crucial. Patient need to be referred early before irreversible end organ failure exists. So now we'll move to the long-term devices, because those are the major players right now in the market, and I think those are the solution for the patients that we heard about earlier in the discussion in this meeting. And as you can see, and I will show you later on, because of the improving results and outcome of those devices, the number of devices that are being implanted worldwide, and you can see in the United States, is growing dramatically, and this is from 2012. This is still unpublished data, but I can tell you that it's more I think, more than 3,000 or even more devices were implanted in 2013. And this is because of two reasons. One, the results are much better, and we have growing evidence of good outcome. And the other alternative, which is heart transplantation, which used to be the gold standard and is still the gold standard, is very limited in availability. And you can see here the number of donors from the International Society of Heart-Lung Transplantation, which is pretty much stable along the years. And the heart failure, as you know, is just getting more and more, and we identify more and more patients that may be benefit from other advanced interventions. So the question is really, when is medical therapy not enough? And when to send a patient for this kind for circulatory support. And we saw this slide earlier, which really schematically showed the natural history of patients with chronic heart failure, which is associated with acute event, and with each event the myocardial injury may contribute to progressive LV dysfunction. And so at some point of time, this deep acute event will end up with the end of life of this patient, or with irreversible changes, and it will be too late. So we do have some window of opportunity. We don't want to be too early because by no way this is not a cure for the patient. It is associated with adverse events. We'll talk about it, but we definitely don't want to be too late because then it's a very expensive procedure and it's not going to help the patient. And we heard a lot earlier that medical therapy for heart failure, it does slow the disease progression. We heard about pacemaker in heart failure, the delayed disease progression, but they never cure the problem and the progress will eventually happen. So maybe one or two words about pulsatile devices because that's how it all started. Initially, the devices were pulsatile because whoever designed those devices saw that we need to try and do devices compared to the normal physiology, which means systole and diastole. However, the pulsatile devices that generate systole and diastole are relatively large, noisy, a lot of moving parts, and they are not durable enough. And with time, what happened, the market moved to a continuous flow devices because our growing experience with those devices showed they are just doing as well. So we used to have paracorporal devices that are still manufactured, but not too many are using it anymore. Maybe the only pulsatile player that still is in the market because we don't have any other better solution yet is the total artificial heart, which has very specific and small indications. So the major players are the continuous flow devices, and it was proved so far that adequate end organ perfusion in normal blood flow can be delivered most of the time. The advantage of those devices, they are smaller, less moving parts, and they are quiet, and we can give them to more patients. They're supposed to be, and they are actually much more durable than the older devices. So the two main technologies or systems that are working, one is the axial flow pumps, and the major player right now is the HeartMate 2 with the axial flow pumps. It's a magnetically suspended rotor inside the housing, and it rotates in a speed of about 7,000 to 1,200 revolutions per minute, and it sucks the blood from the left ventricle and pump it into the aorta. The patient has a cable, we call an electrical cable, it is called the drive line, that penetrating the skin, one of the Achilles heels of those devices, and I hope you will hear about optional solution in the next talk. And this drive line is connected to the brain of the system, the controller, and is powered by two batteries that supply for the whole day, 12 to 14 hours. The other technology is centrifugal pump, and the major player right now is the hardware device. It's also magnetically levitated, and the speed is 2,000 to 3,000 RPM, and from the outside basically it looks the same. You have a drive line and an electrical line that is coming out to the controller and the two batteries, and it's also lasts for almost the whole day. So what you will see as a physician, we have patients with continuous flow devices, and you can see here two patients. One is having a hardware, one is having a HeartMate 2, and unless you know who is having what, I think nobody can tell who is having which device. Both are doing good job. And from the aspect of the patient or you physician, you find a patient that looks normally fine, and if you wear a jacket or a coat, you don't even know that he has a device, and you may have, and if you try to palpate his pulse, he may not have a pulse, and you may not be able to measure his saturation on the finger, and if you try to measure his blood pressure by standard fashions, you may not be able to measure his blood pressure because the pulsatility, if at all, is very small. So you need to rely on other things like asking the patient, how are you? And we can check the temperature, but that's about it. So initially those devices were like forearms of how it is intended to use. It can be as a bridge to transplant, bridge to recovery, long-term therapy, bridge to decision. If you ask me, I believe in the near future, all these separation are very artificial and they will be gone. It will be only a question, does the patient need a VAD or not? If he does, he will have a VAD, and then with time, he will sort out if it will be a bridge to transplant, to recovery, or whatever. Now, bridge to transplantation was the initiative to all those devices, and most of patients can tolerate LVAD only about 10% will require an additional right ventricular assist, and that's why the company is really concentrated on LVAD and less on RVAD. Bridge to recovery, we know that there are some patients that after you implant the device, with time they will recover and maybe you can explant the device. However, currently the results are unpredictable, and yet it is to be discovered who are the patients that will recover and will not fail shortly after removal of the device. I'm not going to concentrate on this at all. The long-term therapy is the major player right now in the market. And the reason that we are doing more and more patients for long-term therapy or you can call them destination therapy is the lack of donors and the successful outcome we have with those devices. Now, we cannot discuss this kind give this kind of talk without mentioning this landmark article, which is already now is maybe of historical standpoint, published in the New England Journal of Medicine in 2001, the REMED study that really opened the era of destination therapy, and by current standards probably we wouldn't accept the results of this study, but nowadays, as I will show you, the results are completely different. But anyway, it compared an optimal medical therapy end-stage heart failure patient who were not transplant candidate, very sick group of patients, to left ventricular assist device from the old version that we are no longer use, and show an improved survival and quality of life in the patient with the LVAD. And what we can see about this slide that pretty much describe what was happening along the years since this REMED study. If we look on the two lower curves that show the optimal medication of those devices, as we had previously, were not changed since 2001 or 7 to now. It's the same optimal medication we are giving. By 12 months, survival is about 20% to this very sick group of patients. And you can see that with the evolution and improvement of those devices today, for the same group of patients in those trials, we can achieve almost 90% 1 year survival. Big change. And this is from the studies. This is real life data from the Intermax. Intermax is the mandatory registry in the United States for all LVADs. And if you look on the blue line, you can see that this is real life data from the States. That by 12 years you have 85% survival, 24 months, like 2 years, like 70% survival in this group of very sick patients. And if you compare it to the outcome we have from heart transplantation coming from the International Society of Heart and Transplantation, 1 year survival and 2 year survival, it's probably better a little bit, but it's approaching those results of heart transplantation. Now we need to take also into account that all these studies that I showed, not the Intermax registry, but the studies really dealt with very sick group of patients who were not transplant candidates. And 61% of the patients were in Intermax profile 1 and 2. I think we have to discuss a few words about this Intermax. Intermax profile is a new profile that we are discussing more and more in the heart failure people, especially those that are dealing with mechanical circulatory support, because most of the patients that we are putting VADs into are patients in New York Heart Association functional class 4 or at least advanced 3B. And we all know that there are dying class 4 patients and there are stable class 4 patients. So they are not the same group of patients. So it's too broad. So what the Intermax profile did, it just took the New York Heart Association functional class 4 and divided to 7 subgroups, 7 profile, 1 to 7. And the lower the number, the sicker you are. So Intermax 1 will be the critical cardiogenic shock dying patient. And Intermax 7 will be the advanced New York Heart Association class 3B. So the Intermax 1 and 2 were the main patient in the studies, very sick group of patients that we know from the analysis of this Intermax that they are independent risk factor for poor outcome. So we try today to shy away from those patients and not to take the patient with Intermax 1 and 2 into LVAD, durable long-term LVAD implantation, maybe to bridge them with temporary devices if it's appropriate, but not directly to go to a durable device like the Heartware or HeartMate, while they are Intermax 1 and 2 because the results are inferior. we try to, I will convince you, I will try to show you that we try to go to Intermax 3 and maybe 4 today. Because it's not only survival, there are also several studies that show the quality of the life of those patients is improving, and it's not only they're improving the quality of life, it's sustainable, at least to the length of those studies. Now, it doesn't come without adverse event. I don't want anybody to think that this is that if the current devices are the ultimate treatment. They are not. They are coming with adverse events and complications. But what we can see, that if we see the old version, the pulsatile devices, or the new version, the continuous devices, you can see a dramatic decrease in all adverse events, whatever they are along the line. The device malfunction is really, it's there, everything is there, but it's low. Bleeding might be a problem, infection, but most of the time it is tolerable. So there are adverse events, but again, we need to compare it to the alternative. And even with those adverse events, those patients are doing really well. So we are, I think that the most important part of the presentation is starting now. So who are the patients? When we need to think about a patient, that we need to think about mechanical circulatory support, a durable one. So this is the most difficult group of patients, the ambulatory patient with advanced heart failure that start to decompensate. So we need to rely on other factors that are known to be associated with worsening prognosis in heart failure, and maybe to use some risk model to help us to make a better reasoning of who are the patients. So there are mainly many prognostic markers known for advanced heart failure, but maybe the more important one are the inability to walk one block without shortness of breath, or heart failure related hospitalization becoming a more important factor, deterioration in renal function as well. So there are several, I just bring it as an example, and there's no one guideline on how to do it because it's too premature. But at least what we do in Medalion, we will use the Seattle Heart Failure Model Calculator, which is freely available on the internet, to try and predict what is the prognosis of the patient without mechanical circulatory support intervention, knowing that this Seattle Heart Failure Model is overestimating the survival. I mean, the prognosis is going to be poorer because several important predictors are not including in this model, like heart failure rehospitalization, because recently in the Journal of American College of Cardiology it was published that if a patient has, by the fourth rehospitalization for heart failure, the median survival of the patient is about 1 year. So this is a very important factor which is not included in the Seattle heart failure model. And in contrast, we have, again, we don't have right now good risk stratification for VADS, but for example, one of the risk stratification, the HeartMate 2 risk score, show us that if we select the right patients, and the right patients are those without end organ failure, those that still did not deteriorate to the point of no reversibility, then we can achieve by 24 months, by 2 years, 84% survival, which is a great number, I believe. So that made Miller and colleagues in a recent publication to come up with some suggested algorithm. By now, I'm not sure that this is the algorithm, but I think it helped us and to try and put some reasoning about it. But I would say if you have a patient with advanced heart failure with low ejection fraction, the patient is on optimal medical management, he had CRT, yes or no, according to indication, he is a NIA 3 or 4, his 6 minutes walk is limited, his peak VO2 is low, and he has frequent rehospitalization because of congestive heart failure. This is the time to discuss this patient with a dedicated heart failure, advanced heart failure clinic that can and try to sort out what direction we think the patient require, whether you need to continue to get the same kind of treatment, whether you need to be a heart transplant candidate, LVAD as a bridge to transplant, or consider LVAD as a destination therapy. So again, I will end up with this slide that we already saw it before. The timing is crucial, and we don't want to be too early, but we definitely don't want to be late, and it's probably better to be a little bit early than too late with the current knowledge that we have. So we aim today and on the Intermax 3 and 4 as our patient, which means that those are stable patients on inotropes or patients with recurrent advanced heart failure that are starting to deteriorate.